we're going to talk about diabetic patients. I like to put at-risk patient because anybody that's neuropathic or has severe, like vascular disease or has severe connective tissue disease is at risk for ulceration, and they need the same attention and care that we would give to a diabetic patient. So everybody comes in with some level of foot deformity. I always say to a student that there's no such thing as like the perfect foot. There's no erectus foot. Everybody seems to have some kind of digital deformity that develops and expands over the course of a lifetime. As people get older, particularly when they take steroids, they have fragile skin. Glycosylation of the tissues we'll talk about in a little detail next. Extrinsic muscle atrophy, intrinsic muscle atrophy as well, called the intrinsic minus foot. Callus formation at sites of pressure, fat pad atrophy that precedes that usually as with the retraction of the toes, drawing back of the toes. Peripheral neuropathy, various types and various degrees of neuropathy, which you should appreciate. And recognize early signs of neuropathy and encourage patients to get in to see their physicians, particularly their podiatrists, when that begins to happen. Autonomic neuropathy or lack of sweating and that dry skin, it doesn't look like the patient has any oil on their skin at all. Also encourage them to get in and get their foot examined. And the presence of equinus, as I keep saying, is like every diabetic has equinus, and it has to do with glycosylation. Vanity. This is the kind of foot that we have to deal with. This is what patients ask us to provide them with in neuropathic, lymphedema, venous insufficiency, and arterial insufficiency conditions. Vanity is probably our greatest challenge to fitting people in diabetic shoes.